Hello, good afternoon, and thank you very much, everybody, for joining us. My name is Patricia Houston. I work for Family Partners of Morris and Sussex counties, and today is joining me Cancer Control Specialist Ashley Purper. Welcome, Ashley.
Thank you. Thank you for having me today.
No, thank you for being here. The topic for today is an introduction to the health disparities in the LGBTQ plus community. And Ashley is going to have a conversation in relation to services, resources, and then at the end, we are going to allow time for Q&A. That part is not going to be recorded.
Great. Thank you so much. Give me 1 second while I pull everything up here.
I just want to let everybody know that all that information is going to be in the description of this video. So if you have any questions at the end or after this presentation, this video is going to be available in the YouTube channel of the organization.
Great. So thank you again for having me. As mentioned, my name is Ashley Purper. I use she, her pronouns. I am a community cancer control specialist with Rutgers Cancer Institute of New Jersey. And today we are going to be having a discussion on some of the health disparities faced by the LGBTQ plus community. So before we get started, I just want to say that this is, a safe space. It's a judgment-free zone intended for learning and growth. Feel free to speak up with any questions, or at the end we will have a Q&A section, which will not be recorded. So if there was anything you felt sensitive about asking, it won't be on record. This is also my email, so feel free to email me after if you have any questions. Typically, I like to start these programs with introductions, but since we are such a small group and many people will be watching this after the fact, if you want to just think about how you can start introducing yourself using your pronouns. As I said at the beginning, my name is Ashley. I use she, her pronouns. It's just a good practice to get into. I do have some pronouns listed here on the screen. We have she, her, hers, he, him, his, they, them, theirs. Just in case anyone is unsure, your pronouns are a way for other people to refer to you. Also keep in mind that people can go by any number or combination of pronouns. Some people might use she, they pronouns, he, they, she, he, they, it's really unique to each person. So today's workshop, we're going to cover the following objectives. We're going to define some terminology and concepts. We're going to understand health disparities and barriers to care, and then we are going to have a discussion on local, state, and national resources for the community. So before we really get started, I do have, if anyone was with us last week, I like to do knowledge check-ins. They're little like pre-tests. So the next few slides are going to be some multiple choice questions or true false statements. We will launch this again at the end of the program, and that's when we will discuss the answers. So this first statement is, what does the LGBTQ acronym stand for? We have option A, lads, girls, bisexual, transgender, queer. Option B, lesbian, guys, bigender, transgender, and queer. Option C, ladies, gay, bisexual, transvestite, queer. Or option D, lesbian, gay, bisexual, transgender, queer. If you feel comfortable, throw your answer in the chat. If not, you can jot it down somewhere or just think about your answer. Again, we will go over these at the end. The next few statements are just true false statements. So true or false, HPV, the human papillomavirus, is known to cause cancer. Is this A, true, or B, false? Another true false statement, LGBTQ populations have the highest rates of tobacco, alcohol, and other drug use. Again, is this A, true, or B, false? And the final statement here is all transgender people are gay. Would this be A, true, or B, false? I do see some answers coming through the chat, which is great. Thank you for being interactive. For anyone, again, watching this at a later time, feel free to jot these down and we will discuss this at the end. So first, we're going to cover some terminology. In order to really understand the health disparities and barriers to care, it's important for us all to have that basic understanding of terms and concepts. So let's get started. First, we're going to really talk about this acronym that we hear so much. So, the first letter of the acronym is the letter L, which stands for lesbian. The term lesbian is used to describe a person who identifies as a woman, being romantically or sexually attracted to other people who identify as women. The second letter is the letter G, which stands for gay. The term gay is used to describe someone who is attracted to members of the same gender as themselves. Most of the time, the word gay is used to describe men who are attracted to other men, but it can also be used to describe women who like other women. The third letter is the letter B, which stands for bisexual. The term bisexual is used, there's kind of a twofold meaning here. The old definition used to be someone who is attracted to both men and women. The newer, more up-to-date description is someone who is bisexual is someone who is attracted to members of the same gender as them, as well as other genders. So they're really starting to get away from that being attracted to only men and women. It's really attracted to someone of your gender as well as other genders. The fourth letter of the acronym is the letter T, which stands for transgender. The term transgender describes someone who does not identify with the sex they were assigned at birth. For example, a transgender woman is someone who was assigned male at birth and identifies as female. On the other hand, a transgender man is someone who was assigned female at birth and identifies as male. One thing to keep in mind when it comes to the transgender community is that people transition in different ways. People can transition medically. This is where they may take hormones, undergo medical procedures. They can transition socially, where they ask people to use a certain name or pronoun, or they may transition legally. And this is where they may legally change their name and gender marker on their legal documents. Some people do transition in all three ways. Others, it's different for everyone. So just really want to emphasize that it looks different for everyone and there's no right or wrong way to transition. The fifth letter of the acronym is the letter Q, which stands for queer. The term queer is used to refer to anyone who is not straight or not cisgender. I did just discuss the term transgender. So the correct term to describe someone who is not transgender is cisgender. The term cisgender describes someone who does identify with the sex they were assigned at birth. For example, my name is Ashley. When I was born, the doctor said, it's a girl. They wrote female on my birth certificate. I also identify as female, so I am a cisgender woman. I know the term queer can sound controversial to some. It has been used as a slur throughout history. However, many people in the community are working to reclaim the term, and it's almost now a catch-all term used to categorize people within the LGBTQ+ population. In some cases, it's used interchangeably with the acronym, which you may hear me say throughout the presentation. I may say the queer community instead of LGBTQ+ community. And that's really just because it's a little bit easier for me to say since I'm talking so much. So it's really that umbrella term. So I just want to say, you may not know all the terms. That's okay. LGBTQ+ people use a variety of terms to describe their identity and to talk about who they are. Pay attention to how people are talking about themselves and then just mirror their language. We really just want to respect that self-identification. In many cases, the LGBTQ acronym is written with a little plus sign at the end. So the plus sign can represent any other sexual or gender identity not included in the L, G, B, and T. Some examples of identities this can represent include intersex, which refers to someone whose reproductive anatomy doesn't neatly fit into those categories of being male or female. Again, just respecting self-identification. Some other terms that can be represented by the plus sign are pansexual, asexual, genderqueer, pangender, omnisexual, and many, many more. Again, you don't really need to know all of these terms. You just want to respect that if someone is identifying as such, that you use the correct terminology. I will share in an email post-workshop a good glossary of terms that really goes into these a lot further if you're interested in reading more about it. So now that we've talked a little bit about the acronym, we just want to talk about the concept of sexual orientation versus gender identity versus sex assigned at birth. So it's important to understand the difference here. So really, what is the difference? Well, to start off, your sex assigned at birth refers to the label that your doctor gives you when you were born, based solely on your anatomy. So if your doctor writes M for male on your birth certificate, that means you were assigned male at birth. And if they write F for female, that means you were assigned female at birth. Again, this is solely based on what the doctor sees when you're born. On the other hand, gender really refers to your innermost concept of self as a male, female, a blend or combination of both, or in some cases, neither. Your gender identity may be the same as your sex assigned at birth, or it may be different. Again, for example, if you're assigned male at birth, but you identify as a woman, your gender identity is a transgender woman. And the inverse is also true. If you were assigned male at birth, and I lost my train of thought there, but you get the point. It can be the same or different whether you're transgender or cisgender. Keep in mind, gender identity is an adjective, not a noun. So when it comes to transgender people, for example, you would want to say transgender people, transgender person. You wouldn't say a group of transgenders or someone transgendered. It really doesn't work in that aspect. It's really the adjective. And last but not least, your sexual orientation refers to who you are attracted to. I mentioned before some of the terms lesbian, gay, bisexual, pansexual. These all refer to a person's sexual orientation. Keep in mind, this can change throughout the course of a person's life. Again, just respect that self-identification. Just to conceptualize it a little bit further, gender identity is who you go to bed as, whereas sexual orientation is who you may go to bed with. And knowing someone's gender identity does not tell you anything at all about their sexual orientation, and vice versa. They are two completely different components. They're two different methods of identity. So now we're going to really dive into the meat and potatoes of this presentation. So we're going to review some common health disparities faced by the community. But first, let's describe what a health disparity is. According to Healthy People 2020, a health disparity is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, physical ability or disability, sexual orientation or gender identity, or any other characteristic historically linked to discrimination. A little bit shorter of a definition here, the CDC, a health disparity is a preventable difference in the burden of disease, injury, and violence. We're going to spend the next portion of today's workshop discussing some of the common disparities. On the screen, you will see some of the most common disparities faced by the LGBTQ+ population. LGBTQ youth are 2 to 3 times more likely to attempt suicide. LGBTQ youth are more likely to be homeless. Lesbians are less likely to get preventative services for cancer. Gay men are at a higher risk of HIV and other STDs, especially among communities of color. Lesbian and bisexual women are more likely to be overweight or obese. Transgender individuals have a high prevalence of HIV and other STDs. LGBTQ+ populations have the highest rates of tobacco, alcohol, and other drug use. And there are high rates of violence against the community. These facts may seem a bit jarring to some of you, so let's briefly discuss some reasons why these disparities may exist. There's often a lot of discrimination from family, peers, the medical community, and other social services. There's oftentimes a lack of health insurance. There's low levels of cultural competency from healthcare providers, a lack of appropriate social services and programs for the community. There's bullying in schools, lack of laws preventing this bullying. There's a lack of safe social spaces. There's been targeted marketing of harmful products, mainly from the tobacco industry, which you'll see on the next slide. I go into this a bit further. And there's also inconsistent collection of SOGI data. SOGI data is that sexual orientation gender identity data in surveys and health records. So it makes it hard to really understand these disparities if we don't have the data on it, and we don't have the data because people aren't collecting it. So now we're going to dive a bit deeper into some of these disparities I mentioned. So we're going to start with smoking and tobacco use in the LGBT community. 20.5% of LGBTQ plus community members partake in the use of tobacco products. Lesbian, gay, and bisexual adults are more likely to use cigarettes and twice as likely to use e-cigarettes. Transgender adults have higher odds of using cigarettes, e-cigarettes, hookah, and cigars. And in addition to using tobacco products at higher rates, youth, sexual minorities were more likely to use tobacco more heavily. Research documenting these health disparities is growing, but there's still very limited national data available regarding tobacco use. The most recent comprehensive countrywide data is from 2016. So we really need, again, there's this urgent need to improve research in the community. But basically all data, past and present, that is being released shows that the LGBTQ community is disproportionately impacted by tobacco. And this, could be due to tobacco companies using a multitude of methods to target the community, including advertising in gay press publications, showing tobacco as a normal part of the LGBTQ lifestyle. They use corporate philanthropy as evidence of support of the community. They participate in giveaways, they increase advertising. They host community outreach efforts at LGBTQ plus specific bars, featuring a specific cigarette brand. And the e-cigarette and vaping companies have really followed suit in this. And some studies show that LGBTQ individuals turn to tobacco more heavily as a coping mechanism due to the added stress of being a minority population. And why is this important? Well, smoking can lead to immediate and chronic health conditions, including lung cancer. If you currently smoke, use vapes or other tobacco products, I will share some resources at the end to help you quit. Now we're going to look at HIV in the community. According to the CDC, in 2018, gay and bisexual men accounted for 69% of all new HIV diagnoses. 1 in 6 gay and bisexual men will be diagnosed with HIV in their lifetime. For Latino and Black men who have sex with men, the rates are 1 in 4 and 1 in 2, respectively. One large international analysis found that transgender women in certain communities have 49 times the odds of living with HIV than the general population. So HIV is a virus that attacks cells that help your body fight infection, making a person more vulnerable to other infections and diseases. HIV can affect anyone, regardless of sexual orientation, race, ethnicity, gender, age, geographic location. However, certain groups of people in the United States are more likely to get HIV than others because of particular factors, including the communities in which they live and what subpopulations they belong to. So some risk behaviors for developing HIV are unprotected sexual behaviors and IV drug use. LGBTQ plus populations and individuals are more likely to partake in IV drug use, thus putting them at a greater risk for HIV infection. LGBTQ plus individuals are also less likely to receive preventative care, making it less likely for them to receive HIV prevention medications, prevention education, etc. Another major disparity we see in the queer community is a high burden of HPV infection. So an estimated 61% of HIV negative and 93% of HIV positive gay and bisexual men have anal HPV infections, compared to 50% of or less of heterosexual men. Only about 25% of gay and bisexual men are knowledgeable about the relationship between HPV and anal cancer. Queer women are less likely to visit and utilize preventative health services, making them less informed about HPV and HPV prevention. And people with a prior HPV infection are 32 times more likely to develop oral cancer than those who have not. So HPV is the human papillomavirus, the most commonly transmitted STI, and is a viral infection. Some strains and infections do clear up on their own. Some strains lead to warts. However, some strains, if left untreated, can lead to cancer. So I just want to point out that women who have sex with women can contract this virus and other STDs from an infected partner in the same way that straight women can, including genital to genital contact, sharing sexual toys without cleaning them properly first. I don't want to say many, but some lesbian women have also experienced heterosexual intercourse, which also increases their risk for HPV. However, lesbians are less likely to regularly visit a reproductive health specialist, the OBGYN, making them less exposed to information about HPV, and they're less likely to use preventative steps. So HPV can lead to several different types of cancer, and the LGBTQ plus community is disproportionately affected by cervical, anal, and oral cancers. So many queer women delay or forego proper preventative care and screening just because they believe they are not at risk for developing STDs, STIs, or HPV. And again, like I noted, women who have sex with women can contract the virus in the same way from an infected partner. Men who have sex with men are also at an increased risk for anal cancer. Since the HPV virus is easily transmitted through skin mucus contact, oral sex is a potential vehicle for transmission. And HPV does seem to play an independent role in the development of about 30% of oral cancers. LGBTQ plus individuals are at a higher risk for HPV infection, thus making them at a higher risk for developing cancer. Which now leads us into cancer. I want to point out there is no biological reason for LGBTQ plus persons to develop cancer at higher rates, but there are social barriers and other social factors that contribute to the queer population being diagnosed at higher rates or at later stages of disease. This is a common development in many chronic diseases, not just cancer, but being from the Cancer Institute, cancer is a major focus of ours. And I also want to point out that disparities exist not only in rates and stages of diagnosis, but also exist in treatment, recovery, and survivorship. Queer women have higher rates of obesity, higher rates of smoking. They are less likely to have biological children, or they have biological children at later ages, meaning they have lower rates of breastfeeding, lower rates of proper screenings, which all put them at higher risk for developing breast cancer. So prostate cancer is one of the most common cancers in men in general. However, men who have sex with men have greater challenges during and post-treatment than the general male population. Again, there is no increased risk for prostate cancer due to sexual orientation, but men who have sex with men are more negatively impacted by the side effects, including issues with sexual intimacy post-diagnosis and post-treatment. But there are very few resources to help men who have sex with men overcome the challenges post-diagnosis and treatment when compared to the general population. The transgender population is also at greater risk for not only developing cancer, but facing many challenges in receiving proper treatment from diagnosis onward, along with having high rates of smoking, drinking, drug use, high rates of HIV leading to a greater chance of cancer. Transgender people also have extremely low rates of proper screening and overall preventative care, leading to diagnosis at later stages. This can be due to fear, discrimination, lack of social services, numerous other factors. It's also important to note that some transgender people feel very disconnected from certain parts of their body. And this disconnect can be very extreme, this gender dysphoria, which causes high rates of psychological distress. It is a very real and very important issue to talk about. So for example, a transgender man, someone who was assigned female at birth, may not seek those gynecological services. They might not be going for their cervical cancer screenings just because of the stress they feel. Or a transgender woman, someone who was assigned male at birth, may not seek proper prostate cancer screenings, etc. So LGBTQ plus people face many barriers to care. We can see here on this screen in this little circle chart graph that there are many factors that contribute to these health disparities, including high rates of homelessness, low rates of health insurance, higher rates of smoking, IV drug use, alcohol use. A lot of these behaviors are due to the added stress and as coping mechanisms that go along with being considered a minority population, such as discrimination, prejudice, stigma from peers, family members, and just the overall community. One major contributing factor is the potential discrimination in the healthcare setting. It has been noted that many LGBT individuals delay or forego going to the doctor due to discrimination or just a lack of culturally competent providers. And again, delaying or not seeking preventative care can lead to undiagnosed disease or receiving a diagnosis at a later stage. One jarring fact that I have found is, according to the National LGBT Cancer Network, 60% of oncologists feel they do not know enough to treat lesbian, gay, and bisexual patients, while 80% feel they do not know enough to treat transgender patients. All of these factors combined with an overall lack of research and data leads to a high disease burden, including HIV, HPV, and cancer. And then here I do just have a quick video that highlights some of the issues that the LGBTQ population faces in healthcare, both as patients and as caregivers. If you were with me last week, you know I love using videos in my presentations because I do think hearing firsthand perspectives really helps with our understanding. So again, just let me know if you can't hear this, but I think we should be okay.
To treat me, you have to know who I am. I identify as the Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man.
When I was about 15 years old, I remember going into the doctor's office, and I remember telling her when she asked about my sexual activity, if if I use condoms or anything like that, and I said, no, I'm gay. And I just remember her face changed very much, and her warm tone of voice turned very harsh, and it seemed as though she was rushing me out as quickly as possible.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
My partner and I and our children were on a family vacation, and my older daughter became sick. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
My partner was hospitalized recently. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have different sexual orientation or different gender identity than the care provider.
The people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it.
When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me, even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status, and upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
Now, I understand a lot of that information can seem very discouraging. It's not always the happiest conversation to have. However, there are resources all across New Jersey that can help the LGBTQ plus population, and we're going to discuss some over the next few slides. First, tobacco cessation. As you may have heard me say probably a million times throughout the presentation that the LGBTQ plus community has extremely high rates of smoking and tobacco use. So there are resources available. We have the NJ Quit Centers, the NJ Quit Line. All of these are completely free. The National Cancer Institute smokefree.gov actually has a specific site for the LGBTQ plus population, which will give free resources. They have a free like texting line where you'll get like free tips like daily to help you stay on track. Again, these are all completely free. Another great resource is the Inspira Quit Center. They have an LGBTQ plus specific quit group that is statewide. It is virtual. It's a meeting to help you stay on track, and you'd be surrounded by individuals that are very supportive, with counselors that are very supportive and very understanding of the unique needs of the LGBTQ plus population. So as we spoke about previously, LGBTQ plus individuals are less likely to seek preventative care. This can be due to discrimination, lack of culturally competent providers. Here are just a very, very few services that are located in New Jersey. I know I wanted to keep it around the Morris area. So there is Edge, New Jersey, located in Denville. They do offer primary care. There is the Babs Sipperstein Proud Center, which is in Somerville. So not quite in Morris, Sussex, but close. There are LGBTQ specific primary care offices around the state. And I will again share a resource that has almost a sort of directory so you can see what's near you. Listed here are just a few other resources. We have PFLAG New Jersey, the Pride Center of New Jersey, Garden State Equality. These offer various services, including advocacy and support groups. Out in Jersey is a very large community portal that provides people with almost a directory with various resources, including primary care offices. The National LGBT Cancer Network is a great hub of information for those affected by cancer in any way. They aim to improve the lives of LGBT cancer survivors by way of education, training, advocacy. They also have resources and information for caregivers. Another great resource guide that I actually found earlier today is the County College of Morris. They have another type of directory that you can sort through providers that are LGBTQ plus competent, and it's broken down by primary care, behavioral health, mental health, all of that. So I will definitely share that link as well. I think that is very important, especially because it is a little bit more local to the area. So for now, we made it back to our knowledge check-in. Yay, another test. Again, these are just these same questions that we asked in the beginning, but now we are going to actually talk about the answers. Again, what does the LGBTQ acronym stand for? Feel free to, again, throw your answer in the chat if it changed, but if you feel like you got it right the first time, no need. So the correct answer here is the letter D. The LGBTQ acronym stands for lesbian, gay, bisexual, transgender, and queer. Now we have moved into our true/false statements. So HPV, the human papillomavirus, is known to cause cancer. A, true, or B, false? This was true. It is known to cause certain cancers. The next true/false statement, LGBTQ plus populations have the highest rates of tobacco, alcohol, and other drug use. A, true, or B, false? Again, this is true. And the final statement, all transgender people are gay. Was this A, true, or B, false? The answer is B, this is false. Remember, knowing someone's gender does not tell you anything about their sexual orientation and vice versa. And we have made it to the end of today's workshop. Again, thank you so much for having me. I do have a QR code here on the screen for an evaluation survey. So if you did sit through the entire workshop, if you could take, I think it takes 2 minutes tops. It's just a survey that helps me improve my programming in the future and also helps the Cancer Institute improve its future programming. I believe now we will have some time for Q&A, and I think we will end the recording.
Thank you very much, Ashley. And now we are going to move to our Q&A session. Thank you.